All right, I think we're gonna get started. More people keep joining as we get going, but welcome everyone to this month's online webinar titled MythBusters Compliance Style. We have a super fun and informative presentation today given by Jake Yates. And before I turn the time over to him, I'm going to briefly introduce him and read his bio. Jake is a seasoned healthcare professional with over 15 years of experience in mental health, risk adjustment, healthcare audits, and compliance. As a compliance consultant, he partners with healthcare organizations to navigate the complex landscape of regulatory requirements and ensure compliance. Jake's expertise spans a wide range of compliance areas, including CMS audits, RAPS and EDS claim submissions, healthcare risk management, and regulatory healthcare compliance. His extensive experience working with top U.S. health insurance plans has equipped him with a deep understanding of healthcare compliance and Medicare Advantage, HEDIS, and RADV audits. Jake has a proven track record of delivering engaging and informative presentations on healthcare compliance, leadership, and a variety of other topics. He has shared his insights with a diverse audience, including nationwide healthcare organizations, professional billing groups, medical groups, and private physician practices. By leveraging his deep industry knowledge and strong communication skills, he empowers healthcare organizations to achieve compliance excellence and drive positive change within each institution. Jake holds a bachelor's degree in social work from the University of Utah and a master's of business administration and healthcare management degree from Western Governors University. His professional certifications include Certified in Healthcare Compliance from Healthcare Compliance Association and Certified Artificial Intelligence Professional in Healthcare Compliance from Comply AIQ. And we are so excited for this presentation. I will also be sending over a recording of this along with the slides in a follow-up email. So with that, I will turn the time over to you, Jake.
Okay, perfect. Thanks, Chelsea. Appreciate it. And thank you, everyone, for taking the time to join today. This is a great webinar. I'm so excited to present on this. So thank you for taking the time out of your schedules to spend some time with me today. All right. So like Josie mentioned, my name is Jake Yates. I'm a compliance consultant and virtual compliance officer here at HCP. And today I'm going to be your Mythbuster. So I love compliance myths. So if you have compliance myths, feel free to throw them in the Q&A. If we get some time, we'll try and answer some of them live. If we don't, we will send out answers to them after the webinar. So watch our LinkedIn page for healthcare compliance pros. If you're not connected with us, great time to connect with us. And then as well with the follow-up email Josie will be sending, we'll put in the answers to any of those that we don't get to today. Our LinkedIn profile will also give you lots of great information about new webinars, other compliance myth, and other great compliance content. And I'll just hint, nudge, nudge that we may have some fun new content coming on May the 4th. So that's all I'll say about that. But let's just say I'm excited for May 4th this year. Now, before we begin with busting these myths in the webinar, please understand I'm not an attorney. So anything I discuss today, don't misconstrue it as legal advice. If you have an audit or some other legal ramifications you're facing with compliance, make sure you consult with a healthcare attorney to help you. So this is meant as a fun, interactive way for us to look at some of these common myths that we've heard and get the facts about them. So for those of you that are not familiar with the TV show MythBusters, let me give you a quick rundown on kind of how it goes. That will make this webinar make a lot more sense. So from a roughly 2003 to 2018, there were two guys, Jamie Heineman and Adam Savage, who were both special effects experts. They did a lot of different special effects for films, movies, TV shows, things like that. So basically the premise of MythBusters is they would take a common or uncommon myth or an urban legend and then use facts and science to demonstrate and really prove whether something was truly a myth or whether it was plausible or whether they could actually confirm it as something that was true. So we're going to follow that same pattern today as we look at these 10 compliance myths you see on the screen. I will say up front, I'm not sure of the origins of all of these myths, or most of them actually, but we're going to investigate them all the same. We hear about them, we've seen them. There's been lots of white papers and other articles published about some of these myths. So, as the Mythbusters would say, please don't try this at home. So, we'll turn this around for our sake and say, please don't do this at home. Do it at work instead. Bust these compliance myths. Also, have to give this content warning that there were no compliance officers harmed in the making of this presentation. All right, so we're going to kick this webinar off with this great compliance myth. The myth is that only providers have to follow HIPAA rules and regulations. Now, I have my suspicions about where this myth came about from and why it is a popular compliance myth. And I believe that really comes from the fact that providers are typically one of the main contributors to a patient medical record. And a lot of people just straight up associate HIPAA with medical records, and providers become the next thought in their mind. But what do you think? Do only providers have to follow HIPAA rules? Let's bust this one. Let's see what the facts really are. Now, as we dive into this one, I will tell you, yes, I'm going to quote regulation, but that's because that's the facts. That's the science in compliance, so that we can really figure out and hone in and determine whether or not something is truly a myth or whether we can bust it. So our first fact in this myth is coming directly from the Department of Health and Human Services. So HHS says, quote, every healthcare provider who transmits health information is a covered entity, and any organization that helps a covered entity with its activities and functions is a business associate, end quote. Now, we're going to see how that ties in. So if you're going, what was the point of that quote? You'll see here in just a minute. If we use that information, that's going to help us better interpret the HIPAA security rule, which ultimately says that covered entities and business associates must do 4 things that you see there on the screen. The first is ensuring the confidentiality, the integrity, and the availability of EPHI, whether that's the covered entity or their business associate, and if they create, receive, maintain, or transmit EPHI. The second one is they're required to protect EPHI against any anticipated threats or hazards to either the security or integrity of EPHI. The third one, they need to protect EPHI against any anticipated uses or disclosures that aren't allowed or that aren't required in the HIPAA privacy or security rules. And the fourth one is really what's going to give us the answer to this one. And fourth, ensure compliance by the workforce of the covered entity or business associate. Well, this leads us to another area we need to clarify. In fact, we need to prove. Who is a workforce member? What does that even mean? Well, again, HHS comes in straight with the facts. A workforce member is defined as a medical provider, administrative staff, intern, student, or even volunteers. So if we put all of this information, all these facts together, basically anyone who works in a doctor's office or covered entity or for one of their business associates has to follow the HIPAA rules. And based on that, we can consider this myth busted. If they work in your organization and they have exposure to PHI, they're a workforce member and they have to follow the HIPAA rules. All right, well, I hope you guys are getting the gist of this and enjoying it. Our next myth, and this is one I continue to hear a lot, and it's going to play into a few other myths we're going to look at today as well. This myth says that only the OCR only investigates large organizations. Now, again, we can kind of speculate on the origin of this myth. Primarily, my understanding and my thought is that it really comes from the number of large organizations we see in the news announcing breaches, ransomware attacks, patient complaints, or other incidents involving PHI. We get blasted with emails, and all kinds of news media outlets will cover these stories. And that's really where I think this kind of misnomer comes from. So let's check it out. Does the OCR only investigate large organizations? Well, let's again start with our facts. What do we know about OCR investigations? Well, we know they typically occur because of a large breach of PHI or a patient complaint against an organization. In the last 12 months or so, there have been over 430 organizations who've reported a breach of more than 500 patients' information to the OCR. And of course, with that would require media notice and things of that nature. Of those just over 430 healthcare organizations, there were 5 kind of top issues that led to an OCR report. The first one was impermissible uses and disclosures. The second was a general lack of safeguards to protect PHI. The third was a lack of access controls. The fourth, a lack of administrative safeguards. And fifth was a lack of technical safeguards. Now, we could do a whole webinar series and even individual webinars just on those 5 different issues by themselves. However, that's not what's going to help us solve this myth. So let's look at actual settlements that the OCRs made. So if we look at the last 12 months of OCR settlements and that they've published for viewing, there's roughly 15 incidents that have occurred in the last 12 months. Well, we don't know the exact criteria that OCR uses to really determine who they're going to have these settlements with. It's pretty safe to assume that the organizations being investigated and that have a settlement announced typically involve more than 500 patients. It's not true in all the cases, but in most of them. There can also be significant evidence that shows that a covered entity or a business associate didn't have appropriate safeguards in place, and that could also lead to a settlement and an investigation of that magnitude. So let's break down the data from these 15 organizations and really see if we can confirm or bust this myth. When we look at it, over 5 of the organizations had over 1,000 employees. Fairly large group. We're talking large medical practices, hospitals, groups of that size. If we combine all 5 of those organizations' HIPAA breach results and the patients impacted, we're looking at just over 194,000 patient records being mishandled or compromised in some way. Now, if we dial that down a little bit more, there's 3 organizations that have between roughly 251 to 500 employees. And if we combine the results of those organizations and their 500 plus HIPAA breaches, we end up with about 90 or 29,000 patient records being breached or mishandled. If we look a little bit further down, we find 2 organizations that had between 51 and 250 employees, and combining their patient breach count, we're looking at about 468,000 patient records being breached or mishandled. Diving it down even further, organizations with between 11 and 50 employees, combined results with those 3 organizations that match that criteria resulted in 15 million patient records being mishandled. Again, 15 million, not even 1,000, significantly more than anything we've looked at to this point. And finally, 2 organizations had between 1 and 10 employees, and combining those 2 organizations, there were over 592,000 patient records breached or mishandled in some way. Now, if we put all that data together, more than half of the OCR's investigations were for organizations with 250 or fewer employees. If we dial it even further down, a third of them, so 5 out of the 15, had 50 or less employees. So based on the facts we have here and what the OCR has investigated and settled, I think it's pretty safe to say this myth is busted. The OCR is going to investigate any organization of any size. It's going to depend on whether or not they had the safeguards in place before the investigation started and before the incident occurred. Ooh, okay. This is one of my favorite myths. I've had many a conversation about this myth with healthcare attorneys, gone to countless webinars on these, including some from the National Institute of Standards and Technology, or NIST, and the Office of the National Coordinator for Health IT. Not sure why government has such long titles, but anyway, government organizations, they both have fantastic information on the importance of a security risk analysis, which of course is an SRA. So let's check out the facts and see if we are actually required to conduct an SRA each year. Now, sorry to quote regulation again at you, but the HIPAA security rule, again, is going to kind of help us out in this fact finding. It states, quote, a covered entity or business associate must conduct an accurate and thorough assessment of potential risks and vulnerabilities to the confidentiality, integrity, and availability of EPHI information held by the covered entity or their business associate, end quote. So in addition to the administrative safeguard I just read from the HIPAA security rule, it also clearly states in the rule in the CFR that conducting an accurate and thorough assessment is a requirement in addition to that verbiage. And it states it literally right there, required. So no getting around that one. SRA does need to be done. But there's a lot of speculation with this myth around the timing and the frequency that it's supposed to be done. So when we really boil it down to the facts, the HIPAA security rule doesn't actually state a specific numerical time frame or frequency to conduct an SRA. Instead, HHS has provided clarification on the frequency with this statement, quote, the risk analysis process should be ongoing. In order for an entity to update and document its security measures as needed, which the rule requires, it should conduct a continuous risk analysis to identify when updates are needed, end quote. So the security rule does not specify how frequently to perform a risk analysis as part of that comprehensive risk management process. The frequency of the performance of an SRA is going to vary between covered entities and business associates. Some may perform one of these analyses annually. It could be biannually, every 3 years. It could be multiple times in a year. It's really just going to depend on the circumstances in your environment and what your unique risks and safeguards are. So, based on these words, straight from HHS, I think it's safe to say that this myth is plausible, depending on your organization. However, I will say, generally speaking, conducting an annual SRA is considered best practice. But the myth is it actually being required to do it annually, which it's not. So if you have any questions about conducting your SRA, just know that you have to do it. It is a requirement to do it. But as far as the timeline goes, you just have to prove your risks and that you're mitigating those risks sufficiently and indicate your time frame from that point to mitigate any risks that occur. Now, reporting incidents to HHS is not a fun experience, but we are all human and mistakes happen. We hear a lot about, again, those large patient breaches because they're in the news, and with the requirement in the HIPAA privacy and security rules to report breaches of over 500 patient records to the media. But what about breaches of 500 or less patients? We typically really don't hear about those unless you find a pop-up notification on someone's website or get a letter in the mail because you're one of the patients impacted. That is generally where probably this myth got started, is just the general lack of such visible transparency that these, we'll say, smaller breaches have occurred. So let's explore this myth a little bit. If you have a HIPAA breach, but it impacts less than 500 patients, do you actually have to report that to the OCR? Now, some of you may have had a breach that would fall in this category, so you already know the answer to this myth, but let's check it out for those that may not have and confirm if this myth is plausible or busted. Now, again, we've got to establish some facts. build our science. First of all, what even is a breach? According to the HIPAA privacy and security rules, a breach is, quote, an acquisition, access, use, or disclosure of PHI that's not permitted by the HIPAA privacy and security rules and which compromises the security or privacy of PHI, end quote. So in its simplest terms, a breach is when someone gets patient information that they don't have a need, a business need, or a right to have. So the rule also indicates three specific instances when a disclosure of PHI is not considered a breach. So we could say that they are exceptions to the rule. The first one is any unintentional acquisition, access, or use of PHI by a workforce member or another person who's acting under the authority of a covered entity or a business associate. What does that mean? Well, let's use an example to kind of break that down. An example of this could be a medical provider. They mistakenly send an email with some EPHI in it to a hospital's billing employee. The billing employee opens the email and then immediately notifies the medical provider and deletes the email. That would be an unintentional acquisition, access, or use of PHI. The second one is an inadvertent disclosure of PHI to another organization or another person who is required to follow the HIPAA rules. So a great example of this would be if a medical provider and a medical coder both share the same office. Both the provider and the coder are authorized to view PHI, but may not be authorized to view the PHI the other is viewing. Third is if there is a, quote, good faith belief that unauthorized recipients would not reasonably have been able to retain the PHI. That one can be a little hairy. So here's another example. Let's say we mail some medical records to a patient or to an address, and it gets discovered that that's not the right address, and then we get the records back. Envelope is sealed. It's the same envelope we sent out. It's same address, everything. We can verify that by looking the package over. We can assume from that that the recipient could not have reasonably read or retained any of the records. So even though they're unauthorized to receive those records, there's no way they basically could have retained them, and we can see that by physically examining that envelope. Same can be said, especially if you have encryption with your software. You can, in a lot of those softwares, be able to see read receipts. So if it's ePHI that's sent, you can tell if the email's been opened and revoke that email with PHI in it if you discover that it's been sent to the wrong place. Now, the second part of this breach exemption looks at kind of a four-factor risk assessment, and that's going to determine if there's a low probability that PHI has been compromised. So there's four additional tasks that kind of provide the evidence we need to verify if there's additional risk. The first is the type of PHI, including identifiers, patient identifiers, and if that can be re-identified. The second, if the person is obligated to protect PHI. So again, kind of going back to our example of another medical provider or business associate who is responsible for handling ePHI. Third, if the PHI was actually viewed or acquired. And fourth, if the receiver can provide a, quote, satisfactory assurance that the PHI won't be used. And that can be done a few different ways, either by confirming that they destroyed it or returning the PHI to your office. Some organizations like to send out attestation forms for individuals who received PHI mistakenly to basically attest and say, yep, I did destroy the PHI. Here's the date I did it. Here's how I destroyed it. I'm not going to use it any further. That's another great way to maintain that documentation if it goes to a party that shouldn't have received it. So now that we've established all of those facts, what constitutes a breach and exceptions to the rules? So what about the actual reporting of a breach? So the HIPAA regulation actually states that if a breach is over 500 patients, again, we have to inform the media, we have to inform the patients impacted. But when we look at those breaches of under 500 patients, or rather, I should correct myself, 500 or less patients, well, we're in luck because, again, the HIPAA privacy rule comes to our aid and tells us what we need to do. So the rule says if your breach impacts 500 or less patients, that the covered entity has to maintain a log of that breach. This can also apply for business associates as well. So each year, that log would be gathered together and submitted to HHS in an annual report, which is due 60 days after the end of the calendar year. So for example, let's say today you had a breach of 251 patient records. You would log that incident in your HIPAA incident log and report that to HHS by the end of February 2027. However, we also have to consider the patient reporting piece of this. Anytime a breach of information happens and it's confirmed and we can't appropriately use the steps we just discussed to mitigate it, we have to inform the patient within 60 days of discovering that breach, regardless of the size, whether it's one patient, whether it's a million patients, doesn't matter. So with all of that lovely information, and there was a lot of it, I think it's safe to say this one is busted as well. Now, I understand not everyone on our webinar today is going to be a business associate, but this is an important myth really to consider for those that are. I get asked a lot by business associates about OSHA applicability and requirements, especially so if some or all of the workforce is remote. And OSHA does provide a lot of guidance around that, and it's very straightforward and very clear. So let's get to testing this myth. Now, if I had to pick one statement that I hear most frequently from business associates, it's, oh, that rule doesn't apply to us because we don't work in an office, or we only work from home, or we're only in a small office. Well, let's take a deeper dive into what OSHA actually says and see if that's true or if it's truly a myth. Generally speaking, OSHA does provide very straightforward guidance in their regulation. In particular, they have a compliance assistance quick start guide on their website that provides a lot of great, straightforward answers to questions about what an organization does and does not have to follow to be compliant. But before we go any further, one important item of note. OSHA state plans do exist, and a lot of times those state plans will have more specific regulations than what we're going to discuss today. So I'm approaching this, generally speaking, from the federal standpoint. If you think you might be in a state or are curious if you're in a state that has more specific OSHA requirements, the link there on the slide right now will take you to the state plan section, and you can find your state and it will guide you to the direct resources so you can see that more specific information that you need to follow. So again, for simplicity's sake, we're going to stick with federal OSHA guidelines along with that compliance assessment quick start guide that they provide as our fact finding for this myth. So the guide in particular really covers what applies to all general industries and employees. So we're talking people that work in, work in medical practices, people that work in an office, a billing company, things like that. So for those of you that are with a covered entity or a patient-facing organization today, OSHA does have a separate guide specifically for healthcare, but these same standards are in that guide as well and would apply in this case too. So let's break this down into 7 categories as we consider this myth. And if you need to wipe your brow, yes, I know 7 categories. We'll try and get through them quickly. First is your hazard communication. Pretty straightforward. If your organization has hazardous chemicals, then you need to have a hazardous communication standard and hazard communication plan. If you use hazardous chemicals, then this OSHA requirement also applies to you. Now, chemicals can come in a lot of different forms, and sometimes we're so used to seeing them in our everyday lives that we don't really consider them harmful or anything we need to worry about. But let's think of some of the common ones. We can consider things like bleach. hand sanitizer, Clorox wipes, even toner for a laser printer, all of those are considered hazardous chemicals. And as a result, if you have them in your workplace, you need to make sure you have a hazard communication plan in case some type of emergency or incident happens with one of those chemicals. The second one kind of ties right into that, your emergency action plan. This is going to really look at what your organization does in case of an emergency. It really focuses more so on broader emergencies, things like fires, floods, can even be a power outage, a tornado, earthquake, hurricane, blizzard, ice storm. I mean, the list goes on and on. I'm sure we could spend a whole webinar just coming up with things that would be included in an emergency action plan. Basically, if one of those things could happen to your organization, you need to have an emergency action plan in place. Really what that does is helps your employees and describes what actions you're going to take to keep you and your workforce safe and what to do in these instances. If you think it can't happen in a remote environment, well, yes, again, it does happen in remote environments as well. Think of things like overloaded power strips, overheated computers, things like that. Those things can start a fire just as easily in a home office as they can in a physical office building. The third one leads right into that, fire safety. If there's a potential for a fire in your organization, well, you need to have a fire safety plan. That includes things like evacuation routes and instructions, designated meeting points, preventative measures like smoke detectors, fire extinguishers, and again, kind of generally your fire safety plan of what you'll do. Again, if you think it can't happen to a business associate, here's a great example. At one of my former employers, we actually had an employee out in a large bullpen area that was working. Their computer spontaneously started smoking and then burst into flames in an office building. We literally were just sitting there and it happened spontaneously. No warning, no anything. We had to do the full evacuation, gathering, head count, all of the different things. So can it happen in an office building? Absolutely. Again, a computer typically doesn't spontaneously burst into flames and smoke, but we wouldn't have thought that it would have either, and it happened to us. So something to consider. Fourth is going to be your exit routes. Again, pretty straightforward. If you have exits, well, then the standard applies to you. So we want to make sure all of our exits are clearly marked in case of an emergency. Fifth is your walking working surfaces. Now, unfortunately, unless we've mastered the art of floating, flying, or teleporting, and if you have, please reach out to me because I would love to learn how to do all of those things. That's what I would want my superpower to be. If we haven't mastered those things, then we need to address our walking and working surfaces. Interestingly enough, slips, trips, and falls are actually some of the most common work-related injury and causes of death in the workplace. So that might kind of leave some of us scratching our heads, but when we look at the data over decades from OSHA, the data doesn't lie. It really, the root cause of a lot of work-related injuries and death is actually slips, trips, and falls, even something as simple and innocent as that may seem. Sixth is our medical and first aid. So OSHA does require all employers to provide medical and first aid supplies and a trained person to administer first aid when needed. They may be trained on CPR or in some cases, even the use of an AED, depending on your organization size. OSHA does provide more specific requirements around that you can find on their website if you are curious whether or not that would apply to you. And finally, electrical hazards. Now, the fact that you're watching this webinar right now means that this is going to apply to you. So in this lovely world of electronics in which we live, we do need to be aware of the various safety hazards that are posed by electricity, overloading power outlets, using extension cords, using damaged extension or electrical cords, even something like using power outlets with wet hands. Now, that last one always gets me. I'm not sure why it has to be spelled out. Well, actually, yes, I am sure why. It's because like the McDonald's hot coffee that had to be labeled that their hot coffee is hot, Multiple someones have plugged in devices with wet hands and electrocuted themselves. So OSHA has spelled it out. Electrical hazards definitely apply to anyone using electricity. Now, that's a lot of facts. So I think it's very safe to say in this case, this myth is busted. OSHA regulations definitely apply to business associates, and even if you are in a remote workforce. Okay, this myth is another great segue from the one we just busted. But for this one, we're going to look at both HIPAA and OSHA compliance. So we may have the potential for two different results. So let's start diving into our facts and see what HHS and OSHA really says about the size of an organization and if there's any correlation to the regulations. I have a few theories. I bet you guys do as well. Now, out of any of the myths we're exploring today, this is probably one of the more frequent ones my colleagues and I get asked about. So for this myth, we're going to need to consider the possibility that this could be confirmed, plausible, or busted depending on the type of compliance we're looking at. So again, for simplicity's sake, we're going to focus on HIPAA and OSHA at that federal level and what those basic federal requirements are. So let's take a quick look at HIPAA privacy and security. Again, HHS comes to our rescue in this case, very clear in the regulations about whether or not the size of an organization really matters when it comes to these compliance regulations. In HHS's exact words, quote, every healthcare provider, health plan, or healthcare clearinghouse, regardless of size, who transmits any health information in electronic form in connection with a transaction is a covered entity, end quote. So simply stated, if you transmit health information electronically, you're a covered entity, and this rule applies to you. When we look at this regulation further, we also see that the HIPAA privacy and security rules are required for organizations that help covered entities, either create, receive, maintain, or transmit PHI, which means our business associates are also included in these regulations. So, does the size of an organization matter when it comes to HIPAA compliance? Well, again, HHS was pretty straightforward on that. The answer is no. This myth is definitely busted. Now, let's look at OSHA compliance. According to the OSHA Act of 1970, each employer is required to provide a place of employment which is free from recognized hazards. Well, straightforward enough, can't argue with that. However, if we dive into the regulation further, there are some injury and illness reporting requirements that are size-based. So according to OSHA, employees with 10 or fewer employees are not required to maintain an OSHA injury or illness log, also known as an OSHA 300 log. However, like everything, there's always an exception. They are still required to report severe injuries that require overnight hospitalization, loss of an eye, or death of an employee within 24 hours for those serious hospitalized or loss of an eye type injuries, or 8 hours if a death occurs at the workplace. Now, these same exceptions and rules are going to apply to organizations that have also been granted a partial exception as well. That can include medical practices, even if you do have more than 10 employees, but we'll stick with our 1 to 10 employees for this myth. So the full list of organization types and things like that can be found on OSHA's website. Otherwise, other than this 1 to 10 exception, really the regulation still applies to any other organizations, and we're required to comply with the OSHA safety standards as they presently are stated. So because this does have one caveat on that 10 or fewer employees, I'm going to have to call this myth, and if you'll excuse the pun, on-screen pun, a little plausible, but mostly busted. You've still got to report these things. No one is completely exempt from reporting serious injuries, hospital stays, or death of an employee in the workplace. All right, so far we've covered and focused primarily on HIPAA and OSHA compliance. But what about corporate compliance? Lots of healthcare organizations receive federal funds from either Medicare or Medicaid, and that does require those organizations to follow very specific corporate compliance requirements. So let's take a look at this myth, which is that checking the list of excluded individuals and entities, known as the LEIE, or more commonly the the OIG exclusion list, and checking the SAM, or the System for Award Management exclusion list, is required to be checked monthly. So our myth is it's a requirement to check the OIG and SAM exclusion lists monthly. Well, according to the Office of Inspector General, the OIG, quote, anyone who hires an individual or entity on the LEIE, again, the OIG exclusion list, may be subject to civil monetary penalties, end quote. Straightforward enough. So I won't go into any more detail on that. If you hire someone that's on the LEIE, you are subject to civil monetary penalties. But what about the myth that you have to check it monthly? Well, there was a special advisory bulletin. It was called The Effects of Exclusion from Participation in Federal Health Programs. Whew. Love, again, another one of those fun long names. This bulletin was published back in 2013 and does clarify and provide some clarity on this myth. So I'll save you all the time. On page 15 of the bulletin, it states, quote, to avoid potential CMP liability, providers should check the LEIE prior to employing or contracting with persons and entities, and periodically check the LEIE to determine the exclusion status of current employees, contractors, and business associates, close quote. It then goes on to say, quote, because there is no statutory or regulatory requirement to check the LEIE, providers may decide how frequently to check the LEIE, end quote. Now, the OIG updates the LEIE monthly. So screening employees, contractors, business associates every month best minimizes your potential for a CMP liability. The bulletin also clarifies that states, so a state itself, is required to screen all of its employees, contractors, and enrolled Medicaid providers monthly. So it is required for a state to screen, again, employees, contractors, and enrolled Medicaid providers monthly. And that is from the official CMS regulation back in 2011. So along those same lines, the SAM exclusion list should also be checked regularly. However, the SAM exclusion list is only updated when changes are made to the list. So it doesn't quite abide by the same frequency and regularity that the LEIE does. Industry best practice has become checking the SAM exclusion list the same time you check the LEIE. Really, again, that's more of a time saver than anything, so that you just do them both at once. It's easy to remember. Again, not a requirement, but something that's widely recognized as a best practice. So what does all of this mean for busting this myth? Well, if the state is required to check employees, contractors, and Medicaid enrolled providers on the LIE each month, they might find an exclusion before you do, and that's likely going to lead to some fines and penalties. So are monthly checks actually required for a healthcare organization? Technically, no. However, it's definitely something that should be done monthly. Otherwise, we may find ourselves in a heap of trouble if the state finds out something about one of our providers before we do. So for fact's sake, I'm going to have to call this one plausible. Again, industry best practice is going to be monthly checks of both the OIG, the SAM, and really your state list as well. All right, this is another one of my favorite compliance myths, and I hear this one a lot. Having policies and training makes my organization compliant, or makes a healthcare organization compliant. Nothing else is needed. Great, let's jump into the facts and really explore this one. So over the years, I've had the chance to attend conferences representing HCP. In fact, I'm looking through those on this call, there are several of you that I've had the chance to meet at some of these conferences. So I'm glad that you're here today. Um, as attendees have come by, I'd say 9 times out of 10, typically the response I get back when I say, hey, do you have everything you need to be HIPAA, OSHA, and corporate compliant? Usually the response I get back is, yep, I have policies, I do training, I'm all set. And they move on. Okay, so the myth we're going to bust in this case is that just having policies and training makes your organization compliant. Well, let's look at some facts here. In 2017, the OIG published the 7 elements of an effective compliance program. Over the years, it's seen minor tweaks and updates and revision, but over the last 9 years, the 7 elements have remained constant. And they've really become the foundation for what the OIG and the OCR use to determine if an organization is compliant and following compliant practices. So simple review of the 7 elements is going to quickly give us a way to bust or confirm this myth. So when we look at the 7 elements, they are as such: having written policies and procedures, compliance leadership and oversight, having training and education, having effective lines of communication with the compliance officer, and having disclosure programs like a compliance hotline, enforcing standards, having a risk assessment, auditing and monitoring practices, and conducting those risk assessments. And last, number 7, responding to detected offenses and developing corrective action initiatives. Mouthful. So even just listing out the 7 elements, we can easily call this myth busted. There's so much more to being compliant than simply policies and training. After all, what good is a policy if you're not taking the action to follow? I can tell you that there's a lot of people that get in trouble for having a policy and not taking action on what's in their policy. So just policies and procedures and your training does not make you compliant. Now, this myth tends to kind of come and go as technology changes and as it continues to become more advanced. So although it's not as common as some of the other myths we've looked at, the rise of AI, because of course we can't have a webinar nowadays without mentioning AI. So there's your token AI mention. So with the rise of AI in healthcare, this myth has kind of resurfaced all over again. So let's look at the facts. Is all health information protected by HIPAA regulations? Well, before we can really evaluate this myth, again, we need to define some terms so that we're all on the same page and know what we're talking about. So protected health information, or PHI, is defined by the OCR as, quote, all individually identifiable health information held or transmitted by a covered entity or its business associate in any form or media, close quote. We also need to look at what individually identifiable health information is. And that's defined as, quote, information, including demographic data, that relates to an individual's past, present, or future physical or mental health or condition, the provision of healthcare to an individual, or the past, present, or future payment for the provision of healthcare to the individual, and that identifies the individual, or for which there's a reasonable basis to believe that we can use that data to identify the individual. I am getting tongue-tied. End quote. That's a mouthful. That's a quote from me. That's a mouthful. In simple terms, the IIHI refers to things like names, addresses, birth dates, social security numbers, and other information that's tied to health information and can identify that individual. So when we boil all of this down, there's really 2 requirements that have to be fulfilled for something to be considered to consider health data as PHI. First, it has to identify an individual's health information. And second, it has to be created, received, stored, or transmitted by a covered entity or their business associate. So what does this mean about health information on things like fitness trackers, or if you have an iPhone, the health app, or some of these other apps that are out there? it basically means that that data is not actually considered PHI and is not protected under HIPAA. However, if the app or tracking device is monitored and tied to your medical records by a doctor's office or another provider, then that organization does have to follow HIPAA rules, and that data in that app or tracker would be considered part of your medical record and is considered PHI, thus it would be regulated under HIPAA. Now, there's 4 categories specifically stated in the HIPAA privacy and security rules that does exclude PHI. And those are going to be your employment records if you work for a covered entity, so for a doctor's office, for example, your employment records as an employer of a covered entity, education records and anything related to your education records under FERPA, de-identified PHI that can't reasonably re-identify an individual, and the final one is identifiers like name, address, email, and so on when it's not maintained in the same designated record as your health information. So the short answer is no, not all health information is protected by HIPAA regulations. So this myth is busted. However, as you can see, there is a lot of health information that is covered under HIPAA. All right, we're coming down to the end. Now for our last myth. This won't happen to my organization. Typically, when I hear this, it's usually followed by the words, well, I've been in business for 20 years and never once had a compliance issue. There's a lot I could say on that, but let's look at the actual data and the facts to see if that's true or busted. Before we do that, though, I have had folks that have said that to me, and funny enough, well, not funny for them, but almost a little bit of karma, I guess. After they said that to me, they got investigated by the OCR or the OIG, and it caused a whole lot of havoc for their organizations. So just because you haven't been audited or investigated does not mean it's never going to happen. So now let's back all of this up with data. When we look again at the last 12 months of reported HIPAA breaches, again, since we have access to the data of more than 500 patients, we're going to utilize that as our basis. More than half of the breaches that have happened at organizations happened at organizations with 250 or less employees. If we look at that a little bit further, a third of all breaches that had more than 500 patient records compromised occurred in organizations with 50 or fewer employees. Now, once upon a time, large organizations were the primary target of hackers, threat actors, but really at this point, those days are over. Yes, they still face these hacking incidents and things like that, but more and more, the trend is shifting to small and medium-sized organizations that are the targets. They may not have as much data as a large organization, but there's still a lot of data that can be gathered in smaller organizations. And when we look at all of that data combined together, and I mean, there's lots more studies and research that would need to be done into this still, but it's likely and reasonable to assume that it's because smaller organizations just simply don't have the same infrastructure and IT resources that a large hospital or large medical center or medical group would have in place to protect PHI. And in essence, that just makes them more susceptible to threat actors and even insider threats. We continue to see instances of insider threats becoming more and more common. In this day and age, we unfortunately just kind of see that it's kind of that gotcha piece. Folks get fired. They want to retaliate against the organization for firing them. So what do? They use their login to the EHR and try and steal data. Or, we've seen instances and cases where employees, even without necessarily maliciously intending, to some degree, that they'll take patient data for their own personal uses to build their own business or other things like that. So sitting and thinking that it's not going to happen in our organization is at this point pretty much wishful thinking. If it hasn't happened, it's because you haven't seen it happen or someone hasn't spoken up to tell you that it has happened, because I can almost guarantee it is happening unless you have the most robust compliance program in the world. These things are happening, we just don't know about them. So when we look at this data specifically for this myth, the real question is it busted? Is it plausible, or is it confirmed? Now, again, an argument can be made that it could be plausible. Again, if we have that just incredible, robust compliance program, maybe our compliance employees outnumber the rest of our employees. We've got people watching every tiny thing like a hawk day in and day out. Unless we've got that kind of a structure happening, I think it's pretty safe to say that we can call this one busted. Even if we do everything right, we are still working in organizations with humans, and humans make mistakes. That's just kind of the fact of the matter. We make mistakes. So having a breach or a hacking incident happen at your organization really is no longer a matter of if it's going to happen. It's really more of a matter of when it's going to happen. So again, having those safeguards in place, making sure we're conducting an annual SRA, and really being informed about our compliance program and promoting that culture of compliance is ultimately what's going to protect our organization. And that's what we're aiming for. We want to protect ourselves from any unnecessary risk. So, what compliance myths have you heard? If you've heard any that I didn't cover today, I would love to hear about them and bust them. Well, that is if I can bust them. Some of them may be plausible, some of them may be confirmed. But any myths we didn't cover today, I would love to answer. And we'd be happy to throw those answers out on our HCP LinkedIn page, as well as along with a copy of this slide deck. So stay tuned, follow myself, and follow HCP on LinkedIn, and we would love to help bust some more of these myths wide open. So thank you, everyone, for joining. If you have any of those myths, we'll leave the webinar open for just a couple minutes to let you throw those in the chat. Until then, looking forward to connecting with you out there in the world virtually, and hope to see you again on another one of our webinars on May the 4th.